Hello, everyone. Welcome. On behalf of Salinas Valley Memorial Healthcare System, thank you for joining us for our virtual Ask the Experts presentation. It's February, so that means it's Heart Month, and we are celebrating. My name is Christiana Kearns, and I'm the Senior Administrative Director of Cardiovascular, Pulmonary, Sleep Medicine, Nutrition, and Rehab Services at Salinas Valley Memorial Healthcare System. Today's presentation is on the minimally invasive transcatheter aortic valve replacement procedure, also known as Tavr. This procedure is for people who have symptomatic severe aortic stenosis and is performed instead of doing open heart surgery. Before we go any further, I'd like to introduce you to our panel of experts. Dr. Patrick Zetterlund is an interventional cardiologist at Salinas Valley Memorial Healthcare System, where he serves as the medical director of our cardiac cath lab and of our cardiovascular research program. Dr. Zetterlund joined Salinas Valley Memorial and Central Coast Cardiology in August of 1994. He sees patients currently at our Salinas Valley Medical Clinic, at the Salinas location and the Monterey location. And new to our cardiac team is Dr. Andreas Sakopoulos. Dr. Sakopoulos joined the healthcare system in June of 2020 and is the new medical director and lead of the cardiothoracic and surgery program at Salinas Valley Memorial. He has more than 30 years of experience in all cardiac, thoracic, and vascular procedures. Dr. Sakopoulos performs multiple different procedures at our hospital. He does CABG, coronary artery bypass grafting, valve replacements, and many others. Dr. Sakopoulos also sees patients at Salinas Valley Medical Clinic's cardiothoracic surgery clinic. Doctors, thank you so much for being here today. As many of you may have noticed, we are not wearing masks, but I want to assure you that we are all being very safe. We are 6 feet apart and practicing social distancing, and we have our masks nearby. So with that, thank you all so much, and doctors, please take it away.
Well, thank you, Christy, for that kind introduction. And we're here to talk about Tavr. It's exciting, as you all can imagine, is that we have a new procedure that is perhaps not as new, but it's new for our community for the last couple of years. Tavr means transcutaneous aortic valve replacement, a minimally invasive way to replace the aortic valve. And it has a lot of excitement. Just think of the difference between having your chest cracked open and spend a week in the hospital versus going home the next day. We'll talk about that later, and Andreas can give you the reasons why we still do that, because we can't offer it to everyone. But about a dozen years or so ago, some very bold individuals in Europe decided that maybe there is a minimally invasive way we can replace the aortic valve. And it's essentially done through the groin and then advance up into the heart, and we can actually take your old valve, push it apart, and put a new valve. And we'll get into that detail in a few moments. Salinas Valley Memorial has been doing this now for a couple of years. So we can offer it without you guys having to go out of the community. And I think that is very big, and that this is something that we can offer that's state of the art. So Andreas, tell us a little bit about good old-fashioned aortic valve surgery as we go forward.
Thank you, Patrick. So surgical aortic valve replacement has indeed been a procedure that we've done for many decades with very good results. But transcatheter aortic valve replacement now gives us another opportunity, another option for replacing the aortic valve rather than doing the operation with open heart surgery. And this is indeed much less invasive. Most patients nowadays can have this procedure done. Not all patients are candidates for transcatheter valve replacements. If they have infection or if they have anatomical reasons why we can't do this, then we will occasionally have to do aortic valve replacements the old-fashioned way. But transcatheter aortic valve replacements clearly are now utilized in more than 50%, maybe close to 70% of patients that need aortic valve replacement, with very good results.
Well, actually, if we look at the data from our own institution, Andreas, I think we're close to 80% in Salinas. And one can ask, well, why do we do perhaps a little bit larger percentage than the national average? And I think it has to do with the demographics of Monterey County. We have a large retirement population, so it's perhaps just representative of the kind of patients that live in our community. I think it's interesting, though, to just look a little bit at the history of the Tavr. So when we were first exposed to this, and I actually personally saw one of these procedures more than a decade ago in Europe, we were only offered the patients you guys didn't want. because this was a high-risk procedure. So this all started out with the surgeon saying, no, we don't want to do this patient. And so we said, hey, let us try. So we tried, and by golly, these patients walked out of the hospital. And then slowly we started more looking at the other patients that were moderate surgical risk and now low surgical risk. So now we've come to a point where Andreas and I can sit down with a patient, and the team sit down with a patient. We can offer all the different options rather than just being focused on one small segment of very sick individuals. So this has become a mainstream procedure where there are individuals that are younger than I am getting it. I think it's very exciting.
Absolutely. The other thing that's very interesting about this procedure is that it's really the first time that a procedure is being done really as a team. If somebody needs open heart surgery, it's done by the heart surgeon with assistants and so forth, but it's really the surgical team. Whereas with transcatheter valve replacement, it clearly is a team approach where different individuals with different talents bring their expertise to the table. So it's always done by a cardiologist, it's Dr. Zutterlin, and a surgeon, usually myself or my associate, Dr. De Filippi. So it's always a multidisciplinary approach. Now, in addition to the work we do, there are other people that work in the background. Dr. Mukai is a cardiologist who looks at all the anatomical details, looks at CAT scans up, down, sideways to make sure that we can offer this procedure and put the right valve in place. The other thing is we have anesthesiologists that help keep our patients sedated, asleep while we do the procedures. And there's a team of technicians and nurses that are fundamental in getting these operations done. So this is much more of a multidisciplinary approach than anything else that we've done.
Yeah, and I think it's also important to recognize Salinas Valley Memorial's hospital commitment to this, because this required a phenomenal amount of personnel, but also financial investment in the equipment and refurbishing our cath lab into a state-of-the-art hybrid suite where we truly have the technology to do this safely and do it right for our patients.
I do want to take up something you mentioned earlier about the patients that get this procedure. So I think it's important for folks to know that not everybody is a candidate for this. There really have to be appropriate criteria. But I would say the vast majority of patients nowadays can have a transcatheter aortic valve replacement. But we do need to do additional testing to make sure that they can have it for anatomical reasons.
No, I think that's very important what you just said, is the team approach to it. So it's the two of us sitting here because we're the ones that actually put the valve in. But I suspect that there is probably another 20, 30 people in the background that are as important as we are, and we could not do it without these individuals. So I put my hands out to them and tell you my appreciation for all that great work. But I think also coming back to who can and who cannot get it, I think we also have evolved in our skills. And when we first started doing this, we were very, very concerned about picking these patients, and we had a lot of criteria and restrictions. And as we have gotten more comfortable, and I think the whole community and our colleagues are across the country and how we interact with each other, because we don't operate in a vacuum. We collaborate with other institutions. We have panels. We go to meetings. We have, Zoom meetings now, obviously, because of the current COVID. As I said, it's a truly collaborative endeavor, I think, across the country that we do this. We also participate in a database, and that database is mandatory for any institution that does TAVRs in the United States. And I think that is very important because we get very accurate feedback information how we perform as an institution and how we compare to the rest of the country, and that we do a good job, because ultimately this is all for our patients.
To your point about the experience we're gaining, we should also mention that the particular valves that we're putting in now are actually third generation valves. So in other words, we are indeed building on top of experience of some pioneer institutions in other parts of the world. So they went from a first model to a second model, and now we're using a third model. What that means is that we are able to deliver these valves in a much more slick way, so to speak, compared to how it was done in the past. We have been able to have these valves compressed to a small size so they can be snaked up from the femoral artery and positioned into through the native aortic valve. In the past, the original valves were much bigger, much more cumbersome to deliver from the groin up to the aorta. So there were more complications. So in reality, the likelihood for anatomical reasons to get the valve in the right position is much more likely this day. The valves are very, very good, easy to work with.
Yes, I would agree, and I think that also the delivery mechanism, the device itself, and without going into the details, have made it much more predictable. And in fact, when we put these valves in, and I try to explain to my patients how we do it, and I think that one of the ways to relate to this is I'm replacing a valve on a running engine, and you can try to do that when you pop the hood. And so there are some of the issues where this valve, as we bring it in and you have a beating heart, and how we then take the heart and we kind of not stop the heart, but we let the heart quiver, so to speak, for lack of better words, to be able to get this valve exactly into a position. And now we're looking at a 20th of an inch while this heart is beating and this valve is rocking back and forth, and now we can stop the heart for a second and then get it right. However, they've also been able to make this valve so forgiving that is, if I don't get it right, I can tell Andreas, why don't you just put the valve back into the little tube and we'll take it out and we go again. So we can actually go back and forth until we feel like we got it absolutely right. And I think that has made it much, much more safer and taken this procedure to the next level.
Yeah, that's a very good point. You know, with open heart surgery, we actually put a patient on the heart-lung machine. We open up the chest, we open up the aorta, we find the valve, we cut it out, and it's all done with the heart being completely still. But as Dr. Zetterlund was saying, with a transcatheter valve, we're putting a valve in without stopping the heart. Now, in reality, we do what's called rapid ventricular pacing usually, and what that does is it makes the heart pressure go down a little bit, but it's just for a few seconds, just enough so we can deploy the valve very accurately. You know, if you put the valve too high, that's not good. If you put it too low, that's not good either. But absolutely, the retrievable mechanism is huge. We're able to deploy it with such accuracy with fantastic results.
And as I said, we don't really want you to move around when we do that, because if you start thrashing around, I may end up putting the valve in the wrong position. So that's really one of the reasons people are under sedation or a very light general anesthesia. And I think that's an important point, is that the patient is under very light anesthesia. That is, when we finish the case, the patient wakes up in a moment. So it's no different perhaps than having your appendix out. So this is not a deep anesthesia. The individual wakes up in the cath lab and with minimal assistance can get over to the bed, and they go to the recovery room, and we usually pride ourselves that the patient is sitting up having lunch. Now compare that with the old-fashioned open heart surgery, where most of the time you go back asleep with a tube still in your throat and then hopefully get the tube out at the end of the day or the next day. So I think that from a patient's standpoint afterwards in the recovery, there is a profound difference. And I mean, I talk to patients that are in the late 80s, early 90s. They go home the next day and they get in the car the following day and go to church. I mean, I think that's striking. I think we have a video that we can actually get ourselves some information and try to explain a little bit to our audience. So here is a computerized animation of a chest where we're focusing on through the heart, and what you see there is the valve opening and closing, and this is a animated representation of a healthy valve. And here now you see a little bit of a green, and it's not just very happy, and it's just sitting there and it's fluttering. And it's a fairly good representation that the valve is not opening and closing. So we back up, and now I think we will see a representation of potential sites how we can get to this valve. And I will tell you why we prefer one spot, but we do have access points. So if you look at the red, which represents your arteries, and this is the vasculature that we want to get in, and we go backwards. So there is an artery in your leg, and that's the one we use most of the time. And there is also an option that you can go into an artery up in your armpit or at the top of your chest. So here you see the actual catheter with a little valve constrained, like Andreas was said, it's all tightened up in this little tube, which is probably about 6 to 1/8 of an inch in diameter. And here the valve comes across your sick valve, and we back out, and here the valve, we can go back and forth like I talked about before until we are absolutely happy where we want it to go. And here is a illustration where we're happy. And now you can see inside this cage a happy new valve, what happens to be a pig valve, which is essentially the same bioprosthetic valve that you would get if you had surgery. But here it is in a self-expanding metal cage. Don't worry, this cage is not going to rust. It's actually made of a chromium alloy, and it's not going to set off any metal detectors.
Let me show a model of the transcatheter valve. You see, this is made out of a cage. It is an alloy that can be constricted, can be completely constricted, but this particular metal, which is mainly nitinol, will always want to go back to its original shape. So we can actually, and inside is porcine. It's made out of pericardium of a pig. And this is the exact same type of valve that we use with open heart surgery, except that rather than being on a nitinol struts, it is on a sewing ring that we sew in place. But the point here is that we can actually constrict the valve within a sheath, within a small tube about the size of a magic marker, maybe a little bit smaller. And it's all constricted. We go up the groin, and when it's in the right position, we allow it to flower. We allow it to open up, and it pops out to its normal size. And it's a little bit bigger than the diameter of the native aortic valve, if that makes sense. So in other words, we put it in, and it fits in snugly, and because the valve is a little bit bigger than the area it's going into, it stays in place.
Just like Andreas was showing earlier, the valve and how it was constrained and delivered, here's another representation of it with a model where we actually see the valve delivered. And you see the aorta, which is the main pipe in the body that goes out down to the groin. So we actually came from below, we went around, and then got into the valve and delivered the valve across your diseased valve with this model right here. So the main pumping chamber that you see here, the muscle representing, is actually the chamber we were talking about that is squeezing the blood. And before you had your valve fixed, they had a very hard time getting across a very tiny little narrowing. So just think of it like as you would be breathing through a straw. Now it's wide open, this ventricle can squeeze happily and the blood will be ejected out in your body. The valve is slightly larger than your own valve, and that is obviously so it pushes against the wall so it won't fly away. Because if you think about it, the heart is going to beat and it's going to want to squirt it out in the body. And if you look carefully at what Andreas just showed, there is this little white ring around it, almost like a felt-like material. And this felt-like material actually goes into the wall of your aorta and will scar up. So this valve, within a few days, 2 weeks, will scar in, and it's not going to go anywhere. And that is very important in long term. So a lot of patients say, well, what happens if I go out and do crazy activities? And I said, no, it's not going to go anywhere because it will scar in. And what happens to your old valve? Believe it or not, we just putty it against the wall. And you say, well, how can you get away with that? And we can get into a lot of details. And that's where we rely on all these people behind us that does all this fancy imaging, because we got to pick the valve correctly. We got to know that when we take your old valve and push it apart, that we push it apart and don't push it into parts of your heart and your coronary arteries that can cause damage. And that's the behind the scenes things that has to be done that is incredibly important, because I think that part of delivering a valve itself is probably one of the easiest part of it, but it's the workup to get to that point is I think that where the art comes in to do this right for the patient.
So to add to what Dr. Zellerman was saying, one of the original pitfalls of this procedure was that we would deploy the valve and it wasn't snug enough around the native valve, and so there was occasionally leakage around the valve. Now there's this layer of felt that Patrick was talking about, and this promotes ingrowths to the tissues around. So we very rarely see leakage. So once these valves are deployed, we're very, very happy with their position. We're very happy with the long-term results.
Well, thank you both very much. That was super informative. So Dr. Zetterlund and Dr. Sakopoulos, as you know, heart disease is the #1 killer in the United States. During the past 12 months of this COVID-19 pandemic, unfortunately, many people have delayed their cardiac care, and the consequences have not been good. What is your message for those that may be watching right now who are delaying their care or who might be afraid to see their doctor?
I've gotten this question many times, and from both patients and from other professionals, but if you have any symptoms or any concerns, don't hesitate to call your doctor, or if you have shortness of breath or chest pains, go to the emergency room. The likelihood of you getting into trouble because of the COVID pandemic is infinitesimal, much smaller than the consequences of you not listening to your own symptoms and getting prompt care.
We have, over the course of the last few months, seen many patients come to the hospital with delayed presentation of their heart problems. So it isn't always a good idea, in fact it is never a good idea, to postpone getting medical care, because if you get your medical care early on, it might be simpler to take care of it. If you wait too long, particularly with heart disease, whether it be a heart attack or a valvular problem, it could be much more advanced, so the treatment will be more difficult.
In fact, when it comes to the Tavr program, even with the impact of the COVID pandemic and all the issues and challenges the hospitals have had in these communities, for all that matter in the United States, we have continued pretty much offering the Tavr throughout this with very minimal disruptions. And that's because the Tavr carries a greater danger and mortality and morbidity than what we are faced with the COVID pandemic and the issues around it. So I think what Andreas is saying, don't delay seeking physician help if you have any concerns or symptoms or have any questions for that matter.
I also would like to add that at Salinas Valley Memorial Hospital, the pandemic, or I should say COVID, is being managed in a very, very effective way. There are 3 or 4 wards with COVID patients that are kept very separate from everybody else. So in reality, we feel very safe working, practicing at SVMH. It's a great place to work, and I think that the administration and all the staff is handling the COVID patients in a very professional manner and in a very safe manner for those of us who don't have COVID.
So, Dr. Zetterlund, can you tell us a little bit about how long the Tavr procedure lasts, and how long does a person have to stay in the hospital after they've had the valve placed?
We started the program a couple of years ago, and we were so excited if we could do this in an hour and a half to 2 hours. That is the procedure from me and Andreas going in, and from what we call skin to skin, we start the procedure and we end the procedure. And now we can do this procedure in 35, 45 minutes. And that, I think, it shows you how we also have progressed in our skill level, but also the technology and the comfort. Now, the length of stay for a patient is predominantly about 80% of our patients go home in 24 hours, and the other 20% stay maybe another day. So you're talking 1 to 2 days in the hospital. The actual time from going from the holding area to the cath lab, having the procedure, and then waking up, we're talking 2 to 3 hours. So it's no longer than it really would be for somebody coming in and having gallbladder surgery.
Dr. Sakopoulos, can you tell the audience a little bit about where this procedure is performed, in the operating room or in the cath lab, and roughly how many people are involved in the procedure?
So this procedure is being done in what we call a hybrid cath lab. The reason we use that word is because it has sophisticated radiographic equipment, so we can take very good pictures, but it's also done in an area that is very sterile, where we could do open heart surgery. So we could open somebody's chest and it would be sterile. The number of people that are involved in this procedure is several. In addition to 2 physician operators, there's usually 2 more assistants by the table. There's an anesthesiologist that keeps the patient asleep or highly sedated. We also have somebody monitoring the echo. In other words, we place a probe inside the throat to look at, that goes into the esophagus, that gives us images on what the heart looks like to make sure that we're deploying in the right position. And then we have other people in the back assisting as well. So it's probably close to a dozen people that are involved in these procedures.
And Dr. Zetterlund, how many Tavr procedures have you performed so far at Salinas Valley Memorial?
Well, a couple of days ago, we passed the 60 mark, and we're up to 61 of them so far, and that puts us in about 45 to 50 patients a year because we just entered our second year of offering Tavr at Salinas Valley Memorial Hospital.
And Dr. Sakopoulos, can you tell us who is not a candidate for a Tavr valve replacement?
So there are people who have associated with the aortic valve problem an aneurysm of the ascending aorta. So in those patients, we have to do a little more complicated operation. Rather than just replacing the aortic valve, we also have to replace the ascending aorta. There are also situations in which the aortic valve is not just diseased, but actually is infected. And those are also situations where we actually have to go in there, take the infected valve out and put a new valve in. The other thing is there are two types of abnormalities of the aortic valve. It can either be very narrow and hardened from calcium, or it can be very leaky. So if it's a stenotic valve, that is a valve that is very calcified, which is the majority of aortic valves, then we can do a transcatheter valve placement. If the valve is very leaky because of various different situations, then there might not be enough calcification around the native aortic valve, so we can't put a transcatheter valve. So in general, those are the limitations. But again, the majority of patients are candidates for transcatheter aortic valve replacements. I should also mention that we have a very long track history regarding surgical aortic valves, and we think that at least the biological valves last 10 to 15 years. The transcatheter valves don't have that history. We don't really know how long they last, but there's no reason to think that they'll last any less than the surgical valves because they are essentially surgical aortic valves. Instead of being mounted on a sewing ring, they're mounted on that nitinol cage.
Dr. Zetterlund, what other options are there for somebody with aortic stenosis? Are there medications someone can take or other types of surgeries?
Well, I'll be very frank with you. Aortic stenosis, as Dr. Sakopoulos stated earlier, is a disease of a narrowing of the valve. And once you develop symptoms such as shortness of breath and fatigue or syncope or end up in the emergency room with heart failure, we know that this valve is so narrow so it cannot open and the body cannot keep up with the demands of the blood flow or lack of blood flow across the aortic valve. So I'll be honest with him, all my patients asked, is there a pill I can take? And I said, unfortunately, there is no Drano that you can take and get rid of this. This is a fixed obstruction, and this is something that we mechanically have to treat.
Dr. Zetterlund, how would a patient go about making an appointment with you for this procedure, and would they need a referral?
Well, we usually get patients referred from their primary care physicians or other cardiologists, but I would just call our coordinator or call our office, and we'd be delighted to see you.
Thank you both so much for all of the great information and for the wise advice as well. If you would like to learn more about our Tavr program, please contact our program director, Ann Timberlake. Ann can be reached by calling 831-759-1992. Again, that's 831-759-1992. Or by emailing her at timberlake@svmh.com. I want to thank Dr. Zetterlund and Dr. Sakopoulos for their time and providing such great information on our Tavr program and procedure. That does it for us. Thank you all so much for coming. Have a happy Heart Month and love your heart, because we certainly do. Thank you.